Today we are breaking down 5 essential things you need to know about central venous accesses before you start your inpatient rotation. Let's get started. Venous accesses comes in 2 main types, peripheral and central. Peripheral access includes the short IV, usually less than 6 centimeters, placed in the hands or the forearms. These are the traditional peripheral IVs. They are used for 3 to 5 days, and the foot should only be used if upper extremity access is not possible. Then we have the midline. These are longer catheters, usually 8 to 20 centimeters, inserted into the upper arm veins. They do not reach central circulation but provide more durable access for 1 to 2 weeks and sometimes up to 4 weeks or 30 days if monitored closely. Now let's talk about central accesses, meaning the catheter tip ends in the central circulation. We'll start with the non-tunneled central lines. These include internal jugular, subclavian, and femoral central lines. They are used for short-term access, usually less than 2 weeks. Subclavian is preferred for short-term use because it's more comfortable and has a lower infection risk, but we avoid subclavian lines in CKD or end-stage renal disease patients because they can cause venous stenosis and compromise future dialysis access. Femoral central lines should be reserved for emergencies or when the internal jugular or subclavian sites are not possible. Now, there are 2 special types of non-tunneled central lines deserve mentioning here. First, temporary dialysis catheter. These are large bore central lines used when a patient needs urgent dialysis or CRRT, which is the continuous renal replacement therapy. They are usually placed in the right internal jugular or femoral vein if IG access is not possible. If the need for dialysis becomes long-term, these should be transitioned to a tunneled dialysis catheter like a permacath. Second, the Cordis, also called an introducer sheath. This is a short, large bore central line that provides rapid access to the central circulation. It is used when we need fast fluid resuscitation, multiple infusions, or placing a Swan-Ganz catheter in the ICU or the OR. Cordis lines are meant for very short-term use, usually hours to a few days. Next, we have PICC lines, peripherally inserted central catheters. These are placed in the arm and their tips end in the superior vena cava or atriocaval junction. PICC lines are used for long-term therapy from several weeks to a few months, and they can handle TPN, antibiotics, chemotherapy, and most continuous infusions. Then we have tunneled central catheters such as Hickman catheters or permacaths. These are designed for long-term and frequent access. They run under the skin before entering the vein, which helps reduce infection risk. They are commonly used for dialysis, parenteral nutrition, and ongoing chemotherapy. And finally, implanted ports, also called porticath. That's one of the brand names. These are fully under the skin catheters. They are accessed only when needed, require very little day-to-day care, and can last for years, often permanently when maintained well. Let's rank these lines in a few different ways. But before that, if you would like to have or receive a written summary of this video, you can access that on my Substack page. The link to my page is provided below. Let's first rank them by how invasive they are. The least invasive is a regular peripheral IV, then comes a midline, followed by a PICC line, then a non-tunneled central venous catheter, then a tunneled central venous catheter, and finally the implanted ports as the most invasive. Let's rank them now by how long they can stay in place. Peripheral IVs last 3 to 5 and sometimes 7 days per the hospital protocol, of course. Non-tunneled central venous catheter lasts days to maybe 2 or 3 weeks. Midlines can stay for 1 to 4 weeks if we take care of them well. PICC lines for several weeks to months. Tunneled catheters for months to years. And implanted ports can last 5 years or longer even. Let's rank them by the infection risk now from the lowest to the highest. Ports and peripheral IVs carry the least risk. Then come midlines, followed by tunneled catheters, then PICC lines, and finally the highest risk of infection, non-tunneled central venous catheters, with femoral lines having the highest infection risk. How about by thrombosis risk, meaning clot formation? The highest risk is with long-term, not short-term, long-term subclavian lines, followed by PICC lines, then femoral lines, then ports, tunneled catheters, and internal jugular lines, and finally midlines and peripheral IVs carry the lowest risk of thrombosis. thrombosis. How about by Phlebitis risk or vein inflammation? This complication is most common with peripheral IVs, then traditional peripheral IVs, then midlines, then PICCs, and it's very rare with other central lines. How about choosing the right access? Now, rule number one, always start with the least invasive option that still meets your patient's needs. Peripheral IVs are the default for short-term therapy. They can handle vasopressors, 3% saline, and other hypertonic saline, also amiodarone drip for 24 to 48 hours, as long as you using a large, well-functioning line, 18 to 20 gauge or larger, and monitor them closely, of course. If peripheral access is difficult, go for ultrasound-guided peripheral IVs, a midline or a central line depending on the situation. If the patient already has a working midline or a PICC line or tunneled catheter or port, use that access unless it's infected or incompatible with the planned therapy. Midlines are great for 1 to 4 weeks of non-vesicant therapy. For example, a patient needing, let's say, 2 weeks of IV antibiotic therapy, midline is perfect. PICC lines are your choice when IV therapy is expected to go beyond 4 weeks or for TPN, and if there is multiple concurrent infusions. Non-tunneled central venous catheter CVC are mainly for critically ill patients who need multiple drips, rapid infusions, or invasive monitoring. Subclavian is preferred for short-term use but should be avoided. Remember that should be avoided in CKD or dialysis patient due to the risk of venous stenosis for them. Right IG is better for these patients. Femoral lines are only for emergency, again, as we said, or when other sites are inaccessible. PICC lines can be used similarly to non-tunneled central venous catheter in critically ill patients, except for hemodynamic monitoring. Tunneled catheters and ports are for long-term use. Tunneled lines for patients needing continuous or frequent access like dialysis or chemotherapy, while ports are better for patients needing intermittent access, not everyday access, over a long period of time with lower infection risk and better comfort, of course. Let's talk about contraindications. Avoid placing peripheral IVs, midlines, or PICC lines in a limb that has a prior mastectomy or axillary node dissection, an AV fistula or graft, an active DVT, infection, burns, or open wounds, or a history of radiation or major trauma. Avoid placing a central line through an infected site, distorted anatomy, or if the target vein is thrombosed or occluded. Also, it's recommended to avoid the site with a chest tube, pacemaker, or existing device. How about coagulopathy? It's generally safe to place a central line if platelets count above 20 to 25,000. If platelets are between 10 and 20,000, consider platelet transfusion before placement. How about elevated INR? For INR 2 to 3, consider correction if the patient is in high risk for bleeding or multiple attempts are expected. And for INR above 3, correct to below 2 before insertions. How about bacteremia? If there is no existing line, a new non-tunneled central catheter can be safely placed under strict aseptic conditions. If there is an existing line, remove it first if you think it's the source of the bacteremia. This is for non-tunneled catheter. Never place a tunneled catheter or port until the bacteremia is clear. We must confirm the proper positioning of the PICC line, a peripheral inserted central line, or centrally inserted central non-tunneled catheters before using them. The tip of the catheter should be at the atriocaval junction at the level of the carina. Post-placement chest X-ray is the gold standard here. Now, some PICC line insertion technology confirm the proper position using ECG guidance with high accuracy. The central venous catheter or guide wire act as an intracardiac electrode, advancing the catheter produce a characteristic increase in P wave amplitude as the tip approaches the atrium, right atrium. There is no need to confirm with the chest X-ray here, but it's not helpful, of course, in patients with atrial fibrillation because they don't have a P wave. Take a look at this chest X-ray. You can see the right IJ in good position here. And here you can see a right IJ temporary dialysis catheter in good position. You see the large bore. And here you see a PICC line also in good position as well. On this X-ray, you can see a right IJ vein permacath with the distal tip at the cavo-atrial junction as well. On this one, you can see the right IJ crossing the midline, overlying the aortic arch. This line is not in good position and should be pulled back or removed. Let's talk about daily care and removal. Ask yourself every day when you're around your patient, does my patient still need a central line? Inspect the site for redness, swelling, or drainage. Keep the dressing clean and intact. Nurses typically flush before and after medications and flush and use lumens daily. Daily chest X-ray is not necessary in patients with CVC, central venous catheter, but if it was done for a reason or another, ensure to review it and confirm the line is still in good position. Remove the line immediately if it's no longer needed or if it's infected or non-functional. When removing for these central lines, lay the patient flat or in Trendelenburg position. Have them hold their breath or perform a Valsalva maneuver and apply gentle traction followed by an occlusive dressing on their side. Common complication of these lines, of course, is central line infection or CLABSI. This is the most important to prevent here. Use full sterile precautions, chlorhexidine preps, and remove the lines as soon as possible. Suspect infection if a patient with a central line develops fever or positive blood cultures after 48 hours. Draw culture from the lines and peripherally. Remove the lines and start antibiotics. Thrombosis is most common with PICC lines and subclavian long-term use. If you notice arm or neck swelling, get an ultrasound, duplex ultrasound right away. Treat with anticoagulation if confirmed. Remove only the line. Remove it only if it's infected or no longer needed. Mechanical issues include pneumothorax, arterial puncture, air embolism, and catheter malpositions. So always confirm placement and use ultrasound guidance whenever possible. Catheter dysfunction can present as sluggish flow or inability to draw blood. Try repositioning or gentle flushing, never force it. If occluded cath flow, 2 mg, 30 to 120 minutes dwell can be used to restore functions. Again, let's go over some special scenario which already mentioned in CKD or end-stage renal disease. Avoid subclavian and PICC lines to preserve future dialysis access. Use IG or femoral if temporary access is needed in these patients. In cancer patients, ports are best for long-term intermittent therapy. For patients going home on IV antibiotics, midlines or PICC lines are ideal, depends on the duration. And let's finish by summary and takeaways. Start again with the least invasive option. Midlines are great for 1 to 4 weeks of therapy. If longer, they use PICC line. And PICCs are best for long-term or outpatient IV therapy. Non-tunneled central venous catheters are for emergencies or short-term use access. Remove the lines as soon as they're no longer needed to prevent infections. Always confirm the proper positioning of PICC lines and non-tunneled central venous catheter before using them. In the end, if you found this video helpful, I'm sure you will like my previous videos on this course or list about chest tubes, NG tube, about PICC tube, and about Foley catheters. Links to those to that list is provided below. Again, you can receive a written summary of this video by subscribing to my Substack page. All these useful links you will find them in the description field. Thanks for watching, and I'll see you soon.